period was stable or regressed in more than 60% of people. And in a study by Qian Liu, 21% of the eyes required surgery, only 21% in 4 years required surgery. So they had their own indications for surgery. So what are the indications? Most of the times if the visual acuity is less than 612, because better than that, a patient may have some improvement in metamorphopsia. If the patient is very symptomatic about metamorphopsia, then you may operate. Otherwise, better not to touch those eyes if the patient is not symptomatic. Just because you are seeing an ERM, better not to operate. Any recent vision loss complained by the patient? Definitely yes. And grade 2 ERMs, definitely gas grading as classically described in the textbooks. I took these images from the textbook only. So grade 2 epiretinal membranes are definitely indicated for surgery. In that also, you just look at the requirement of the patient, especially this the more than 80 years of age group. And on OCT, look for either a diffuse adhesion or a focal multiple adhesions. Most of the secondary membranes are like, they show focal multiple adhesions. And points to look for are like central foveal thickness, disruption of the photoreceptor inner segment, outer segment junction, and ectopic inner foveal layer, VMT, lamellar macular hole. Lamellar macular hole has a poor prognosis compared to a pseudo hole. There is a definite confusion between LMH and pseudo hole. So if you look at this particular thing, this is a pseudo hole, and this where there is a loss of retinal tissue because of the rupture of the cystic spaces, that is actually a lamellar macular hole, but they are used interchangeably. And any vitelliform lesion, and the disorganized disorganized outer retinal layers, they carry the poorer prognosis. So these are the things which we look for in OCT. And during surgery, definitely look for absence of PVD, especially from the disc. There may be, because PVD is a prerequisite, at least partial PVD is a prerequisite for ERM formation. So still there may be vitreous attached to the disc, so PVD induction is a must. You should not miss that. And staining for removal of the membranes and ILM peeling supposedly adds to prevent the recurrences. And definitely look for peripheral lesions or breaks to prevent the complications. So worst outcome is with those who present with poor visual acuity. But if the patient is coming with 660, they may improve up to 618 only, they may not go to 66. But the more lines of improvement are seen with poor visual acuity. So they have better quality of life when you are looking at the quality of life. So this is what the literature says. And longer duration of symptoms, definitely worse outcome. And the visual acuity improvement is not immediate. One should impress upon the patient when they are counseling for it, because 2 to 3 line improvement in 75% of patients happens over a period of 6 to 12 months after removal of the epiretinal membrane. So definitely combined cataracts VR surgery adds to the better prognosis, and complications reduce it. If you look at this, small preretinal hemorrhages may not matter much, but you may see vitreous hemorrhage which is not clearing, and subretinal hemorrhages also may happen if you have torn the retina while peeling the ERM, cataract, and retinal breaks, the extrafoveal macular holes also do happen. Retinal detachment and recurrence is only 20% around 2 years in most of the studies. More common with young patients. And ILM peeling, as I already said, ILM peeling and use of some steroids, intravitreal steroids, supposedly reduces the chances. So coming to the full thickness macular hole, it has lot of discussions and many classifications. You can look at this table. The textbook only is quoting this table, and there are, if you go to the literature, there are many people have given their own kind of classifications and grading systems and other things. So macular hole is most discussed thing, especially in terms of prognosis and the results. So stage 1 holes, if you look at the studies, 29% remained stable for 1 year, 48% regressed. So this is almost like a higher side of the VMT. So 48% definitely regress. So stage 1, better not to think about. And stage 2, definitely they progress. So from stage 2 onwards, you have to consider surgery. And stage 3 and 4, they rarely close. So one study showed that followed up for 5 years and none of them closed. So OCT, though there are many parameters, many calculations, many formulae that were derived, as on today, most of the literature says that minimum hole width is the one which we are looking at to prognosticate. And there are many things like hole diameter as already mentioned, and defects, and also intraretinal cystic changes, epiretinal proliferation. Definitely epiretinal proliferation, which we usually encounter when we do the surgery, it definitely reduces the prognosis. And like there are many papers which predict that lower the gauge, the better the prognosis, and lot many things are there. ILM peeling with or without staining, and extent of ILM peeling. And yeah, definitely they say larger the hole, larger the extent of ILM peeling. ILM flap also, pedicle flap or free flap or temporal flap, drape it or stuff it, lot many variations are there. And whether to cover the hole or the fill the hole with some other material other than the ILM, there are lot many things, including the smile lenticule also have been described. And relaxing retinotomy is also described to let the hole close and form another hole on the other side. So tamponade, there is a lot of discussion regarding that also. Nil positioning, avoid after the tamponade, and even positioning also. Avoid supine is one concept, only for 1 to 2 days is one concept, only for 5 to 7 days. Lot many literature is available. But if you look at the meta-analysis thing, this is just published this month, and they say that pars plana vitrectomy with or without internal limiting membrane peel for macular hole, they found that almost similar visual outcomes in the end. Almost similar, but definitely macular hole closure increases in larger holes. That's what they want to say. And in this meta-analysis also, they say less than 400 microns holes. So there are like lot many meta-analysis also. I could find at least 40 meta-analysis only regarding macular hole when I search for the literature. So I didn't name this title as guidelines or recommendations. I just want to name that as currently widely accepted points. ILM peeling for all holes, more than 90% success rate compared to 50% success only in no ILM peel eyes. So if at all your hole is not closing, if the hole diameter is less than 400 microns, if they say it should be 100%. So if your surgery is not giving that result, then reconsider your surgical technique. That's what I would like to say, because the literature is saying that it is the highest success rate if you do ILM peeling in less than 400 microns. And ILM flap, better for larger holes, cover the hole and do not stuff. Other material is for resurgeries, and definitely till it closes, hole needs to be protected from fluid in vitreous. So prone positioning does help, and choose tamponade accordingly. And complications, there are many this thing, but reopening of holes was described in pre-ILM peeling era. More common with larger holes, and it was 7% in pre-ILM peeling era. Macular traction, I have only another 4 slides. So study of the natural history says that, spontaneous resolution happens in 20% over 18 months, and it is stable in 60%, and vision is also stable. So you can always discuss with the patient what they want and what exactly they are feeling. And full thickness macular hole may happen in 12% and ERM in 20%. So this is a case where I waited for a month, and the VMT got relieved. The patient is one-eyed, came back, he was under my follow-up only, came back with drop in vision 612, he was previously 6.6. Then when I saw the OCT, it was VMT, I didn't immediately go for it. Then when I waited for a month, that got relieved, and 6.6 came back. So one should wait whenever you are seeing acute VMT. And poor prognosis if it is a broad-based attachment. Cystic spaces beyond the area of adhesion is most important, and if it is associated with epiretinal membrane, then also a poor prognosis. And treatment outcomes, they say visual acuity improvement happens only in 65% even if you operate, and complications are seen in 20%. And pharmacological vitreolysis was not encouraging, and it showed more changes on significant changes on ERG. So that ocriplasmin was not widely accepted. Gas injection, somehow it has not gained importance, but yeah, it relieved in 50% patients in 1 to 3 months. So inject something into the either saline or gas. Gas was preferred, but I think this needs exploration for VMT cases if at all they want to treat. And coming to the submacular hemorrhage, this was one patient with trauma who improved without any intervention from 660 to 618. in 1 month and 6 in another 1 year. And he maintained for 10 years like this. And this is a AMD with large submacular hemorrhage, only anti-VEGF treatment, and the disciform scar at the macula prompted me not to go for any gas injection. And then she got the clearance of the hemorrhage. So what is the natural course? Best prognosis without treatment in post-trauma young patients, but poor prognosis if it is associated with AMD. The problem is that we don't know what are the criteria to intervene. There are many people who intervene even for a smallest hemorrhage. There are many people who doesn't intervene even for largest hemorrhage. So till date, there are no established criteria regarding size, thickness and duration to determine the prognosis for this, whether to wait or to treat. There are multiple combinations. As on today, the literature says it is surgeon's choice. There is no recommendation what to go for and which situation. It is all, as on today, everyone is doing by their choice. So this patient, which was treated only with TPA and anti-VEGF and gas injection, cleared in a day. So thank you. Sir.
Okay, let me just keep it brief. Dr. Krishnendu as well as Dr. Rama have covered almost all the prognostic factors. Some factors as far as the AMD is concerned, despite the treatment, there is a significant number of patients will continue to lose vision. So the 7-up study showed that nearly about 1/3 of the patients will decline, about like half of them may remain stable. So that's something which we need to remember despite whatever we do. Another factor which I battle with is the occurrence of geographic atrophy when we start giving the anti-VEGF. So there comes a stage when there is significant amount of geographic atrophy. In addition, the patient has exudative activity. And if we give further anti-VEGF, whether the geographic atrophy gets worse. So that's a concern. So there I kind of balance between closely following up the patient to see if there is one line loss or if there is edema worsening as compared to the last visit, then I give an injection. Otherwise, I don't try to make the macula dry. So that's something which I battle with. So that's another thing which we have to look out for. Though we can prognosticate, say, yes, of course, there is obvious vacuolation or outer retinal tubules. You know that this patient is not going to do well in the long run. But if you're seeing the patient for the first time, I would still inject to see if the patient improves by 1 line, 2 lines, and then decide about continuing the treatment or not. But more importantly now for prognosticating to see whether we have to inject at that point in time or not is where we have to look at the geographic atrophy which is occurring as we continue to give the injection. As far as CSC is concerned, if it's a middle-aged patient around 40, 45, 50 with a CSC, then we need to look at the pachychoroid disease. So that would indicate that look at it more carefully to see if there is a pachychoroid disease which is mimicking a CSC or if it is a CSC. That will help us decide on the prognosis and also to see if in case he has to be followed up closely for the other eye disease development. And myopic macular the myopic maculopathy, the moment the patient comes, we don't jump in and operate, though the OCT may look scary. If there is a recent loss of vision because of full thickness macular hole and a macular detachment, yes, we operate. But if it is just a tractional schisis and the patient has come for a routine checkup with a slow loss in vision, no harm in waiting for a month or to see if in case there is a progression of the myopic maculopathy and then decide on the treatment, because sometimes this can remain stable. Vitreomacular interface disorders, it's very tempting to jump in and operate, but studies have shown that many of them remain stable. Nearly about 75-80% of them remain stable over the next 3 to 4 years. So there is no need to jump in and operate, particularly if they are asymptomatic. If they are symptomatic and progressive loss in vision, then we jump in and operate. Otherwise, VMT can be watched as well. In fact, I have my own sister-in-law who had a myopic traction maculopathy whom I operated. She improved from 624 or 636 to 66. But she is absolutely unhappy because she has metamorphopsia. On one side, she is saying gross metamorphopsia, which was probably obscured by the fact that she had poor vision before. Now that her vision has improved, now she is noticing it, and she is saying that I cannot use my better eye as well. Not that better eye is better. Better eye also, she's got a VMT with inner layer hole. But then now, though her vision is 6.6, she's absolutely unhappy. I'm unable to help her in any way. Now it's 1.5 years, 2 years, and recently she had cataract, and cataract made it even worse. When she had the cataract, she was not able to see it that time. Now the cataract surgery is done, it's even worse. She is absolutely miserable. So that's something which we have no answer about. So consider carefully before you do the surgery, and you can always consider that it's my sister-in-law. So most stress.
Yeah, one should consider these factors
Yeah,
before
correct.
deciding a surgery, definitely.
That's why I'm not touching your other eye. A subretinal hemorrhage, yes, like there are some indications to say that like subretinal surgery is not required for all subretinal hemorrhages. There are recently at least two papers which say that like intravitreal TPA with intraretinal gas is as good as doing a vitrectomy with subretinal gas and subretinal TPA. I would do vitrectomy now only if there is a breakthrough vitreous hemorrhage and that we are not able to see the macula. Otherwise, intravitreal TPA with gas is as good as not doing a vitrectomy.
Thank you, sir.